So this patient, she was around 55 years, uh, an elderly lady who presented with abdominal pain. She has a history of endometrial carcinoma, which they operated recently. And she was presenting with abdominal pain. We did an ultrasound. There was just mild fluid, but nothing else to explain the patient's pain. So they had asked for a CT. So these are the CT images. I'll scroll through. So this is the representative coronal image. And this, does anybody have any thoughts for this?
I have a guess, but I want to let people online. Anyone want to chat in or give some guesses?
So another clue is, so she also has a, she's had a prior Roux-en-Y gastrectomy.
Yes, so
Gastric
GW says internal hernia. And I'm also thinking that the SMV looks kind of kinked and pulled into possibly an internal hernia.
So yes, this was an internal hernia. It was not obstructed, but if you see here, the SMV has this beaked appearance, and on the axials there is mesenteric swelling. So we suggested the diagnosis of an internal hernia. The surgeons were not very convinced because there was no obstruction, but the imaging features were quite supportive of that. And we had a prior CT in which if you see the relations of the SMA and SMV were maintained and there was no swelling. So even the jejunostomy was located anteriorly here previously, that had moved posteriorly. So right here. So we suggested, and they operated it, and it was an internal hernia through the Peterson's defect.
That's very cool. That's pretty scary kinking of the SMV there.
Yes. So I think we had discussed a few cases a while ago, I think a few months ago, where I forgot someone had showed a few interesting cases of internal hernia. Yeah, this is the first time that I actually diagnosed a case, because I thought earlier I thought I was not very confident, but there's a nice article in radiology by the team from Ottawa, where they have given a flow chart for diagnose. Like they did an analysis of all the possible signs, and they came up with two flow charts. And they found that the SMV beaking and swirling are the most sensitive specific signs, and they have given a flow chart on the basis of that. So that's a good article to read.
Good, that's a great case.
Yeah,
Okay.
that was my case.
Okay, cool. I'm going to show my cases. Melina, are you there? One of them is, I think, yours. Okay, you guys can see my screen, right? Okay, so there was a, oh, there's a chat box. Okay, hold on. Yes, you can see it. Okay, Melina, you can pipe in when I get to your case, or anytime actually. So this was the T2, and this patient had a prior left nephrectomy. You can see that they have this big hernia here. And on the right side, you can see they have this heterogeneous mass. And then they also have this, this process going on in the spleen. And I'll show you the post-contrast images. So this is the renal mass. And this is the splenic lesion. So what do you guys think about both of these? Omar, since you're on, I'm going to quiz you.
They look the same. I wonder if it's the same process.
Yeah, but have you seen RC? So do you think it's like an angiosarcoma going to the kidney, or do you think it's an RCC going to the spleen?
I haven't personally seen RCC go to spleen, but I guess that's possible.
Yeah, so this was the question in this case, which is that we were suspicious that this was a clear cell RCC. It had a lot of like necrosis centrally. But the urologist, said, hey, aren't most splenic lesions benign? Like every time we get a incidental splenic lesion on our MRI reports, you guys tell us you don't know what it is, but it's likely benign. So why doesn't this fall into that category? And it was exactly what we said, exactly what you said. This looks just like, the daughter here looks just like the mother. And therefore we suspect that this is a MET. They did a biopsy of the splenic lesion. So you can biopsy the spleen. And it came back RCC, and they've now subsequently resected. This was actually a grade 4 sarcomatoid clear cell RCC, and this was extensive METs. So I looked it up, and basically splenic METs are very rare. They usually come from actually breast or lung cancer. Obviously lymphoma is a whole other category, but oh yeah, Ben got it, RCC to spleen. But it's actually very rare for RCC to go to the spleen, which didn't make that much sense to me because RCC is hematogenious, and it likes to go, for example, to the pancreas, which we think is because the pancreas is so vascular. So at least in this article, I don't know if you guys can see this, but basically they said that there are several theories on why RCC doesn't go to the spleen. One is because of the angle of the splenic artery, which impairs the migration of tumor to the spleen. They also think that there's physiologic contractile activity of the spleen squeezing out tumor emboli. But basically, I think this comes down to that the spleen is very vascular, but it also has very high flow in it. So it might be more difficult for the tumor cells to kind of get into the spleen and then actually lodge there. And then they also has a high concentration of lymphoid tissue. And that lymphoid tissue could be anti-tumoral, the same way that now we have all this immunologic therapy for cancer. So these are some of the theories on why it's very rare to get RCC to the spleen. Any other comments? Okay. My next case is this one. I'm going to ask Ben to give some comments. Ben, where are you from?
Hi, I'm a fellow currently at Mayo Clinic, Arizona. I grew up in New York.
Oh, cool. So you're with Cookie and Nelly?
Yes.
Okay, cool. So what do you think about this case?
So it seems to be very low and very anterior in the uterus. And I wonder if it's sitting in a scar or even potentially extrauterine. I don't know if I definitively see uterine tissue around the gestational sac.
Yeah, so we were concerned. So this is basically the uterus. This was, we thought, the area of the cervix. We see this thick, kind of rind here, and then a little fetal pole possibly. So yes, everybody is getting Amar and GW. So yeah, this was what we thought was a cervical ectopic. And the fetal pole did not have a heart rate. You can see here. So they wanted to get some more information about it. So we ended up doing an MRI, and this is the MRI. They just wanted to kind of, they were already very suspicious. It was a cervical ectopic. The fetal pole didn't have a heart rate. So just wanted to show you the MR correlation. This one is a little motion degraded, but you can see that you can't really see the fetal pole very well here on the T2. And even here, you can see that it's definitely, very, very low. It looks like it's in the cervix. It's got a lot of flow voids in the ectopic. We still can't really see the fetal pole very well. But interestingly, on the ADC, you can actually see it right there. And we did give contrast because they wanted to see how vascularized this, this whole process was. And now you can kind of nicely see that ring of fire of this low, cervical ectopic. The fetal pole is not enhancing, probably because it was not viable. So yeah, this was a cervical ectopic. So they gave methotrexate, and they're planning to do a DNC. You have to be very careful doing a DNC because it can lead to both catastrophic hemorrhage as well as uterine rupture. Sometimes they just use methotrexate. And the other thing you have to distinguish it from is an abortion in transit. So if there was a miscarriage happening, it could be seen in the cervix and it could be mistaken for a cervical ectopic. But this one was very vascularized. This looked like a real ectopic. Any questions? Okay, who wants to take this case? Teresa?
Sure.
I think this is one of your cases, Melina. Omar gave these to me, so I am sharing them with the world. So the patient had a right lower quadrant pain. And the finding is kind of on this image, but I'll scroll through. Any thoughts, Teresa? In this area here.
Sorry, I didn't realize I was muted.
That's okay.
I'm like, I know, I just said it was inflammatory changes in the right lower quadrant. It looks like there's a diverticulum off of the small bowel. So I'm most concerned for Meckel's diverticulum that's inflamed.
Yeah, perfect. So this is a beautiful example of a Meckel's coming off of, looks like ileum. So it could have been, somebody asked, GW said jejunal diverticulitis, which could be, but more likely on this left upper quadrant here. So right lower quadrant, we're always going to think about a Meckel's. And then they also made a really nice call in the pancreas.
Ductal dilatation, maybe a ductal cutoff sign in the body.
Yeah, exactly. And they did get an MRI, and I'll show you the MRI. So we've got ductal dilation with some side branches, and then you said a ductal cutoff sign, good.
Mm-hmm.
So what are you concerned about?
I don't see a discrete mass there. I mean, always concerned about underlying mass, but it could also be a main duct IPMN. Is that some...
Yeah, so there's a really abrupt transition. You see, there's no, even though it's atrophic, that nice bright tissue, and then this really dark tissue.
Okay, so now I am more concerned about a mass sitting there.
Yeah, exactly. So
I really like the T1 for pancreas non-con.
Yeah, that T1 was beautiful. And then this is the arterial, and you can see the duct, and then maybe a hypoenhancing area, and then this arterially enhancing stuff. And then when you correlate with that, with the pre, it was, that's kind of right where you see the duct, then this, then the nice bright normal kind of even the atrophic pancreas. So anyway, this was biopsied, and this was pancreatic cancer.
Oh, wow.
So this was a good incidental pickup of before, and it's still resectable. So this type of, in this area, they could still do basically just a distal pancreatectomy. It's not involving any of the vessels. So this is kind of a great location for it, but the symptoms would present later because it's not obstructing, causing jaundice or anything. So it's good that they caught it at this point.
I also have a case when you guys are done.
Oh, good. Who said that?
Teresa, sorry.
Oh, sweet. Nice. Okay. I just have a couple more.
Teresa is one of our fellows.
Yeah, I know. I was just pimping her. and your other fellow, Ben, because you weren't here yet. So they were on the, and also my fellow Omar. So, okay, this is the next case. You can see that this is a pregnant patient. And we can see there's no ventriculomegaly, nice fluid-filled lungs, heart grossly normal. Looks like the stomach is within the abdominal cavity. We don't see any hydronephrosis of the kidneys. And then this is the bladder. So this patient had pain. So anyone have any thoughts here? Right lower quadrant pain. So this is the fetus and the uterine cavity, and then I will show you maybe the T1 as well.
Definitely a mass there in the right lower quadrant.
Yes, good. So there is this mass here in the right
So-
lower quadrant, and it has some T1 hyperintensity. We did not give contrast. You can also see there's like a little bit of T1 hyperintensity within the fetal bowel, which is kind of normal. So what do you think
Where are the
this
ovaries?
mass is?
Probably the right adnexa.
Yeah, exactly. So this was the right ovary, and it looked enlarged. It had this T1 hyperintense, probably hemorrhagic lesion. So we were concerned about hemorrhagic torsion here. And actually, Melina, I think this was your case. They took the patient to the OR, and it came.
The gonadal vessels are abnormal too. They're a little dilated, maybe.
Yeah, I didn't think I saw like a definite swirling. Maybe a little. It doesn't look out of proportion to me to normal pregnancy.
Yeah, we
So
also
show
don't
them
see
the diffusion restriction too was have like really restricting diffusion.
Okay. So very restricting here. So anyway, they went to the OR, and this was a torsed ovary, but it also had a large hemorrhagic cyst, and the actual remainder of the ovary was viable. And so they resected the ovary. So the big hemorrhagic part, I think, wasn't necessarily just like hemorrhagic infarction of the ovary. It was a big hemorrhagic cyst. They removed that and detorsed the ovary and then put it back inside the patient. So they were able to save the ovary. So that hemorrhagic cyst was the lead point for the torsion.
Yes, Aarti, that was my case. And I followed up the OR report. It's interesting. We thought that it was hemorrhagic infarction. Also, I think there may have been an ultrasound for this case as well before the MR that didn't show a cyst. So it's interesting that they found this. I mean, we can see that it's a cyst, but it's just interesting that we didn't think that it was a cyst because of all the very irregular borders. We thought that it was just blood in the ovary.
Okay, I'm trying to pull up the ultrasound without showing patient information. Hold on one second. That's why you're getting a blank screen here.
The cystic portion was also like restricting, which is kind of weird. Like the non-T1 hyperintense portions were restricting diffusion.
Oh, it might have been ischemic, I guess, but they decided to save it.
Okay.
Yeah, sorry, I'm still getting through. These ultrasounds are not helping me at the moment. One is an abdominal one, and one is like a few images from a biophysical profile. So I can't find
The
it.
abdominal one is the one.
Oh, okay. And they looked at the ovaries?
Yeah, I think so.
Okay. I'm doing a cine through the ovary, I think.
Yes.
Which I think that is that big hemorrhagic thing. Maybe like just in retrospect, you know, like maybe that's like the hemorrhagic cyst part and that's part of the ovary.
Yeah, you're probably right. So that, yeah, at that time we thought that this was also an enlarged ovary torsed, but we didn't comment on a cyst.
Yeah. Yeah. Either way, they have to go to the OR. So, but yeah.
And it would be very hard to call prospectively.
Yes. Okay, I think that might be it. Let me just see this one. Oh yeah, that's it for me. I'm going to stop sharing. Okay, Teresa, you want to go?
Sorry, unmute, yes. Let me figure out how to share. This is a patient that I think an older gentleman presented to the ER with abdominal pain. So I'm just going to scroll through it. Okay.
Any thoughts, anyone?
And an infectious aortitis.
Yes, good.
Okay, yes.
GW also says mycotic pseudoaneurysm. Cameron
Yes.
says aortitis, and Amar says mycotic aneurysm.
Okay, so yes, yes, and yes. We don't call these mycotic aneurysms anymore. They're called inflammatory pseudoaneurysms. So here you can see the pseudoaneurysm portion of it, but that is not what makes this case super cool. So I want you guys to keep looking. Hold on. I'm sorry, I don't know. Oh, no. Close your eyes.
Did you say it's called an infectious aneurysm or pseudoaneurysm?
No, pseudoaneurysm. Infectious pseudoaneurysm. You're not supposed to say mycotic aneurysm because they're not technically, fungal related. All of them aren't. Okay, so keep looking.
Is there a mass in the right lower quadrant involving like the TI?
Yeah, cecum, TI, you're right.
And actually they say like if you see gas in a mycotic aneurysm, you should go look for a colon cancer because it could
Yes,
be
because it can be what? So this patient is septic.
Is it Clostridium bovis?
Close. There's two different bugs that are associated with this, and they each have one of those terms in it. So one is Clostridium septicum, and the other one is Strep bovis. So this patient ended up having Clostridium septicum.
Cool. And then was it a cancer of the small bowel or the?
I think it was the terminal ileum and cecum. I actually don't have the. I didn't follow up on that immediately. So
Very
I don't
cool.
have the
I've only,
exact
like,
location, but it looks like the cecum and terminal ileum.
I've only read about that. And then every time I see gas in one of these, I'm like, oh, we got to go look for a colon cancer. And I've never actually found one. So.
Yeah. All right, that's all I got.
Amar says, wow.
Let me, yeah, you know how cool it is when you can tell the ER, oh yes, this is Clostridium septicum. You're like, what?
I have one more. It's kind of, it's not, I'll just share it
Okay.
quickly. And then if anybody else has any.
I have one case.
Okay, go.
Okay, this is a patient who is status post OLT, these old studies. The bottom right is, there's like a 6 month interval between the bottom right, which is original post-op, and then the top images are like 6 months later. I've been reading about bile ducts pathology. So this is, I presented a PSC before it, and so this is another bile duct abnormality. What do you guys think?
Nelly, I'm confused. You said bottom right was immediate.
Post-op, yeah.
And then the
like
top is 1 month after.
6 months, yeah, 6 months later.
And then what is the bottom left?
It's like in the interim, like a month after. So it's, this one is like post-op, and then this one is kind of like a month later, and then this is 6 months later.
What was the patient operated for?
OLT.
What was the reason for the transplant?
Oh, the original, that's, I'm sorry. This is like a case from 10 years ago.
But it
I'm
was
sorry.
PSC, presumably.
No, it's a post-op. So this is the liver transplant. Yeah. So what do you think about the bile ducts?
I guess what he's asking is like if the patient had been operated for PSC, then there is that chance that they can get recurrent PSC.
Oh, I see what you're saying. Yeah. No, I don't think. I'm not sure what the primary if the patient had PSC originally. Sorry, I can look it up. But this isn't PSA.
It to me looks like there's some central disappearance of the ducts.
Yeah, exactly. So what do you think?
Some kind of like cholangitis, like it could be an immune related, there could be PTLD. I don't know if IgG4 is more common post-transplant.
Yeah. So I mean, I like I said, I wanted to learn more about ductal abnormalities and stuff like that. So I looked. So yeah, this patient has like irregular central ducts, and it persisted, and then so we were concerned for cholangiopathy, ischemic cholangiopathy, and I think, and so I read into this a little bit, and I think this really, for me, was informative. So bile ducts, there's different vascular supplies, and the distribution of what is affected varies. So the peripheral ducts are supplied, have dual supply, whereas the central ducts and the hilar ducts are single, like supplied by sort of not dual but single source. So the peripheral ducts, they get supply from like the intercostal and the phrenics, in addition to the like the main hepatic arteries. So in ischemic cholangiopathy, the peripheral ducts are spared because of that dual supply. So in ischemic cholangiopathy, typically the central ducts are affected because those usually just have single supply from the hilar plexus. And so with ischemic cholangiopathy, we see more central duct being impacted. So as Aarti mentioned, there's like the central ducts are diminutive in the like liver transplant. So when I think about cholangiopathy in ischemia, I always think that, like, oh, or is it thrombosis, right? The hepatic artery thrombosis, because bile ducts are solely supplied by the arterial system. And I learned recently that in liver transplant patient, they don't have to have thrombosis. There's a condition called ischemic type biliary lesions, which look identical to ischemic cholangiopathy in liver transplant patient and it's not like from HAT, hepatic artery thrombosis. And this condition is felt to be immune mediated and injury from bile cells. So for me, that was informative because, I see ischemic or bile ducts, and I'm thinking cholangiopathy, ischemic in origin, and I don't see a hepatic artery thrombosis. And at least for me now, it's like, okay, well, in liver transplant, you don't have to have concurrent HAT. There's a lot of different causes of ischemic cholangiopathy, but in liver transplant patient, it can also be immune mediated as well. That's it.
That's super cool, Nelly. You know what? You know how you also, in that, can you show that slide again where you showed
Oh, yeah.
central and peripheral supply?
Yeah. Oh, hold on. Okay, yeah, go ahead.
This one. So you're saying the central area, because it only has sole supply, will be more affected, right?
Yeah.
But then you're saying the peripheral ducts are also supplied by phrenics and intercostals, but won't all of those vessels be transected and not transplanted along with the liver?
That's a great question.
I mean, that's actually what I thought was the reason that liver transplants are more susceptible to hepatic arterial injury than if you did like a angio procedure where you embolize the hepatic artery.
Yeah.
Because of that lack of those peripheral supplies.
Yeah. No, that's a really great point. And maybe, that you're right. That, in non-transplant patients, so there's a lot of different causes of ischemic cholangiopathy. So there's embolization, radiation, HIV, sickle cell. There's HHT from shunting, hypoxia. So maybe in those cases, it's predominantly central ducts that are affected. But maybe in OLT, it's not necessarily just central ducts, but it could be peripheral because you get transection from the intercostals and phrenics from the transplant.
Cool. I didn't know about this other thing, ITBL. That's cool. Okay, anyone else have a case? I'll show a quick one. It's kind of a consult. And basically it's just the forever challenging placental abnormality, abnormal placentation question. This was a patient who was 33 weeks and they asked if there was a placenta accreta. And this is always a challenge for me. I know this is not the highest resolution, but a couple of things that I didn't really see are some of the things that we look for are T2 hypointense bands and then large irregular vessels. I thought these were like the normal kind of bands in the placenta. And I didn't see any definite large abnormal vessels. One area where I thought we could see the placental myometrial interface better was possibly on this diffusion, which I was wondering if like this was mainly the placenta and then this is mainly the myometrium. Something one of my colleagues, Amir, pointed out to me was that really you should be doing these exams when the patient is 26 to 30 weeks, because by the time it gets to like this stage, like 35 weeks or 33 weeks, the placenta is, the myometrium is so thin that you might not be able to easily see that interface. And then I'm just going to show you one article that had some good examples of placenta, accreta, etc. So this is the article. So first of all, they said this was basically normal placenta. And on the normal placenta, you can normally see some thin bands like this. You can normally see some, like a couple of vessels here. That's pretty normal. And then this is placenta accreta. They said these are the thick T2 hypointense bands. And there's vessels at the placental myometrial interface. I'm not sure I can tell the difference between that and this vessel in a normal placenta. In the example they give, this is a AJR article. But I think these T2 hypointense bands are what they frequently talk about. Here's another one with these T2 hypointense bands. And also showing previa, so covering the os. And here's some more bands here. And then this is per accreta, where it's going, this is much easier to diagnose an MRI. It's usually often affiliated with a C-section scar, so it's going through the C-section scar, or it could be even invading the top of the bladder. And you can see it kind of puckering, all those vessels are going like right through the myometrium. Any comments?
Aarti, I'm not an expert on this, but I have never myself seen, and every time I look at the literature about these abnormalities, always the placenta accreta that when it's in a placenta accreta, it's either anterior or it's low lying.
Yeah, exactly. So those are the risk factors, is if you have like prior C-section and prior, I think per C-section is the highest risk factor, maybe also DNC. But this one, because it was posterior, we felt even also better about it. On ultrasound, they were saying that they couldn't see the myometrium well, but I think it might be because it was so far along in pregnancy.
Mm-hmm. Yeah, so I think the suspicion for a high placenta like this and posterior would be much lower than if it was a different location.
Yeah. Yeah, cool. And then I thought this was probably a fibroid. That's just incidental, but. Okay, that's it for me. Anyone else?
Say, Aarti, was that increta or accreta? Are we able to differentiate that?
One, I think both accreta and increta are very difficult on MRI. I think percreta is the one you can be most definitive about. And then the accreta versus increta, I honestly can't tell the difference, but the literature at least talks about, anterior, low-lying, history of C-section, T2 hypointense bands, large abnormal vessels. But I also have fetal experts on speed dials in case I ever see anything that's close to that. I'm going to just call them and kind of ask them.
Yeah, it's always been a very difficult thing to diagnose those.
Yeah.
I find it very challenging.
Yeah,
totally agree.
Okay, I think that's it.